Hi, everyone. I can see that people are starting to join, and I always like to give it a few seconds so people can join to the audio and can hear me before I fully get started. But I am so excited to see so many people joining us and really excited to get started today. So I might as well go ahead and introduce myself. So my name is Joanna Tenkate, and I work at Global Heart Hub as their patient community engagement and development lead. And I'm excited to be here today. So for anyone who doesn't know, Global Heart Hub is an alliance of heart patient organizations and advocates aiming to create a unified global voice for those living with or affected by heart disease. So this is a part of Global Heart Hub's Empower webinar series, where we partner with patient organizations around the world to respond to the questions and needs of patients. And this webinar is being jointly hosted by Global Heart Hub and the Irish Coalition for People Living with Obesity and the European Coalition for People Living with Obesity in support of the shared commitment to reaching and empowering the global patient community and creating a collective voice. I want to welcome everyone to today's session. Today, we're going to be talking about the links between obesity and cardiovascular disease to help demystify those links for patients and highlight the need for comprehensive, compassionate healthcare. Just as a bit of housekeeping, automated translated captions are available in the captions button if you would like to see captions in over 35 languages. I also want to note that this webinar is being recorded and will be made available online after the event. And with that, I'm excited to introduce our speakers today who will be covering this important issue. First, we're going to be hearing from Professor Carol LaRue, who is the director of the Metabolic Medicine Group at the University College Dublin. And then we're going to hear from two patient advocates. First, we have Susie Burney, who's also the executive director of ICPO, and Claire Flower, a patient advocate living with obesity and cardiovascular disease. And they're going to be sharing from their lived experiences and highlight the changes they want to see for patients. Lastly, we'll hear from ECPO's Executive Director, Vicki Mooney, who will give us a snapshot on exciting developments and progress being made across the healthcare landscape and really what that means for patients. So to get us started, I'm going to be handing it over now to Professor LaRue for his presentation. And he's welcome to go ahead and start sharing his slides.
I'm just sharing now. Just want to make sure that that you can see the slides in presentation mode. There we are. Let me just double check. Joanna, can you confirm that you can see that?
Looking good.
Fantastic. Well, it's really my pleasure to be here. I'm Carl LaRue. I'm a clinician scientist, and I sort of started my career really focusing on preventing cardiovascular disease by treating dyslipidemia, and statins were just coming out, and it really revolutionized how we could reduce people's risk. Now, my work is mostly focused on the disease of obesity and understanding this link between obesity and cardiovascular disease. So I'm starting today with this very famous painting from Salvador Dali called Persistence of Memory. And the reason I'm starting with this is one of the most famous paintings in the world that depicts science and also shows how time has an influence and the relativity of time. Because you don't have to go very far back, maybe as far as 10 years, and people genuinely thought that obesity was not a disease, it was people's fault. And you're going to hear today more from our patient experts about how that has changed as time goes on. But also, people thought that obesity was a cause for cardiovascular disease. But of course, what we always do in science is if we think something causes a disease, for example, obesity causes cardiovascular disease, then we only can be certain if we reduce the level of obesity and the cardiovascular disease reduces. And unfortunately, for the last 50 years, we were not able to show that causative link. Because every time we tried to treat the disease of obesity and cause weight loss, we were either completely unable to show any change in cardiovascular disease, or in fact, we showed that we made cardiovascular disease worse. So there was a big question around this. So for example, when we used diet and exercise approaches, so my mother would tell you that if you diet and you exercise, you will have fewer heart attacks. But my mother, unfortunately, was wrong, because when we studied that in the so-called look-ahead study, we showed no benefit, even after 10 years of follow-up. Then we thought, well, maybe if we use medications, we can help people, treat the disease of obesity, help them have weight loss, and that will reduce cardiovascular disease. And in fact, we again showed that did not work. And that was with sibutramine, where we actually made the cardiovascular disease worse. So this question lingered until very recently. Now, this is my conflicts of interest, and we work with lots of different companies, with pharmaceutical companies, with nutrition companies, and also with surgical companies, because we do not think obesity is one disease, and therefore we need multiple treatments. But what we do not do anymore as good doctors is ask people, as you would see on the right-hand side, to eat less and move more, thinking that that is going to reduce cardiovascular disease, or in fact that that's going to treat the disease of obesity. So this is a very famous Greek character, Sisyphus, that was meant to roll this rock up this hill, and every time he got to the top of the hill, the rock would roll down, and he would have to start all over again. And that is what happens to you and me if somebody asks us to eat less and move more. We can do that for a period of time, but we can't continue it in the long term, and hence it's not a successful treatment. So we need modern medicine to actually change it. The modern medicine can be nutritional therapies, that's modern medicine. It can be exercise therapies, it can be pharmacotherapies, it can be surgical therapies. We need more modern medicine to actually change not only the disease of obesity, but also cardiovascular disease. Now, of course, if we focus on obesity, you can see that there's multiple complications, not only cardiovascular disease, but you can also see type 2 diabetes, cancer, so multiple diseases. And we also know that people who do have cardiovascular disease, they also have multiple other diseases. And so what we want to do now is we want to disrupt these diseases from progressing. Now, how do we do that? Can we, for example, treat the disease of obesity and therefore disrupt the complications such as type 2 diabetes, or such as osteoarthritis, or such as cardiovascular disease, or such as cancer? So that's really the scientific question that we are dealing with at the moment, so that we can help people who are in your situation, for example, with better treatments. Now, I'm going to show you one study that was recently revolutionized the field, and I'm going to use this not to advocate only for this type of treatment, but to show you how our thinking has changed so that we can bring a better scientific understanding to reducing cardiovascular disease, especially by treating the disease of obesity. So this was called a SELECT study. There was more than 17,000 patients, 41 countries. And what these patients had to do is they were randomized to either having best diet and exercise advice plus placebo, or best diet and exercise advice plus the medication. Now that's important, because the people who had the placebo treatment also had the best diet and exercise advice for the reduction of cardiovascular disease. This was not an obesity study. This study was primarily focused on answering the question whether or not we can reduce cardiovascular disease. So important to say that it compared the usual care, the best usual care we had, which was diet and exercise advice to reduce cardiovascular disease, and it compared it to diet and exercise advice plus the medication. But we needed 17,000 patients because we are so good today at addressing cardiovascular disease. So, for example, many of you would be on excellent therapies, things like statins or ACE inhibitors, or if you have diabetes, on metformin, etc. All of these medications have been shown to reduce cardiovascular disease. And what we need to do is be on top of that, be better. So important to say that we do not want people to stop medications that have proven to reduce cardiovascular disease, because we have been doing so well over the last 20 years at reducing events and also reducing re-events in people, in the Western world. So this is a success story. So what we now have to do is build on the success story. How can we add value to this? And that's the reason why we needed so many patients in the study, is because our current standard of care is already very good. So you should be pleased where we are now. And now we need to work out how can we do even better. So all the patients that were recruited in this study, they did not have type 2 diabetes. And the reason is people with type 2 diabetes are at much higher risk of having cardiovascular disease, but we also have already good evidence that this class of medication, together with our other treatments like statins and ACE inhibitors, can further reduce cardiovascular disease. So this only focused on people that did not have type 2 diabetes, because this is where the question really lingered and focused. Now, the patients that were included in this study looked very similar to many patients that come to a cardiovascular clinic. So these patients had a prior myocardial infarction or stroke or symptomatic peripheral arterial disease. Now, the reason why that's important is that increases the risk of having another event. So if you've previously had one of these, that means we have to do everything in our power to reduce the risk of this happening again. Now, patients were recruited whether or not they were male or female, age over 45. But everybody had to have a body mass index above 27 kilograms per meter squared. So that allowed us to see whether or not, if we reduce the excess fat cells, excess adipose tissue, whether or not that can significantly improve people's risk. So this looked like the patients that come to a cardiovascular clinic, and therefore the results that we now see is applicable to the general population. So first of all, what did people look like? Now, the first thing you will see on the left-hand side, they recruited almost 3 males for every 1 female that they recruited in the study. Now, that's not because the doctors were bad doctors and only favored recruiting males. That's because when we go to a coronary care unit and we look at which patients came in yesterday with heart attacks or strokes, it looks very similar. There's more males with events at the moment than females. Now, that's very different to when we just go to an obesity study, because then we see almost 80%, 70-80% of people recruited into obesity studies are female, and the minority are males. So here we see an inverse because of the biology of the disease. You can see that people were older, about 61 years rather, and there was a mixture because there was 41 different countries. There was different ethnicities that were recruited. Most of the patients, almost 2/3 of them, entered the study with a heart attack, a previous heart attack. About 17% had previous strokes, and about 4% had peripheral arterial disease. So it tells us that we are not maybe focusing enough on those patients with peripheral arterial disease, and we know that's a very important risk factor. So we also learned from the study that we need to pay attention to multiple aspects. Not only people with heart attacks, but people with other cardiovascular risk factors are just as important. Now, remember, these patients did not have type 2 diabetes. Their BMIs on average was about 33. The kidney function was intact, but you can see that about a quarter of patients had heart failure. Now, that is becoming more and more important to you and me and also hospital systems, because we are now able to diagnose heart failure earlier, and we're able to actually manage it. And we have much, much better medications than we've ever had for heart failure. And of course, as more people survive a heart attack, what you do is you have more people with heart damage and therefore at risk of heart failure. And that's something that you and I need to be attentive of, and we need to ask our doctors about, the risk of developing heart failure, and if you have any signs of it, because that is something that can now be very well treated. But on the far left and at the bottom, you can also see that there was almost 2/3 of people with pre-diabetes. That means they were at very high risk of developing diabetes. They didn't yet have diabetes, but they were at very high risk. And that's also another major benefit that we can see from treating people with heart attacks who have obesity, is we can also address their risk of developing diabetes. Now, this is the most important slide, and what it shows is that if you have a treatment that treats the disease of obesity and you continue the treatment, lifelong, what you are able to achieve is weight loss and weight loss maintenance. So the weight goes down and it stays down. Now, the amount of weight loss is quite important because remember I referred back to the look ahead study. That was when we used a diet and exercise approach in people with type 2 diabetes who've previously had heart disease. And what we showed is that you had to get 10% weight loss, double-digit weight loss. So that's about 1.5 stone, 2 stone for most people before you have benefit. So the amount of weight loss appears to be important. Now, this study achieved approximately 10% weight loss, just about 9.5% to be accurate. And this appears to be the minimum that we need to have before we have significant value. So if we have a really good treatment, but we don't get double-digit weight loss, we don't think it's good enough. And therefore, we need to have something that is substantially better. So that could be a nutritional approach, it could be an exercise approach, and people can respond to that. It could be a pharmacological approach, but we need double-digit weight loss. But I think the most critical aspect of this slide tells us that if we have a treatment and the purpose of the treatment is to reduce the risk of having another heart attack, you have to continue the treatment. So if you start with a nutritional approach or an exercise approach, it has to be for the rest of your life. Because the minute you stop that treatment, you stop a nutritional approach, stop exercise, stop a medication, what will happen is the disease of obesity will come back, it will relapse, and the weight will follow. It's not because you've done anything wrong or the treatment isn't good, it's because the disease of obesity is relapsing. And that's the hardest thing for people to understand. And I remember about 20 years ago when we had statins that really revolutionized cardiovascular disease, people would come to us and say, okay, doctor, I'm prepared to take these statins, but when can I stop? And we had to explain to people that you can only stop the statins if you are ready to redevelop another risk of heart attack. Now, we say the same thing when it comes to these nutritional approaches or pharmacological approaches for the disease of obesity. If you stop those treatments, what will happen is the disease of obesity will relapse, and therefore we will lose all the benefits. Now, if you think about taking this treatment and the purpose of this treatment is to reduce your risk of heart attacks, then it's much easier to understand that you need a long-term treatment to really get those benefits. And these are the major benefits that could be achieved. A 20% reduction in what's called a major adverse cardiovascular event. And the data, when we get 10% or more weight loss with a nutritional approach is very similar. It's about 20-21%. And that's reassuring. So that means we are actually able to make a difference. But I want to focus your attention how quickly it starts. Even at 6 months or 12 months, these lines are separating. So that means that these treatments have benefits beyond weight loss. So it's not only the weight loss that drives it, it's also the reduction in inflammation, or the reduction in blood pressure, or the improvements in glycemia, the risk of developing diabetes, for example. So you could see that the benefits start early. And that's why we want to start the treatment, we want to work as hard as we can with patients, and we want to maintain the benefit, because although the benefit starts early, it becomes more and more, and you can see how those lines are becoming further apart, and that is why we need to continue the treatment in the long term. Now, it's not only these major cardiovascular events that has changed. We're also looking at the reduction in death. And that is death driven by cardiovascular disease, or also cumulative death from all causes. And remember that I said that we were really interested in the multiple complications of obesity, and that includes not only cardiovascular disease, but also cancer. Now, we don't have the real evidence at the moment for cancer reduction with medication or with nutritional approaches, but we do have it with bariatric surgery. So bariatric surgery, and especially in females, appear to reduce cancer by 40%. But again, that's when you get 15 or 20% weight loss. So it tells us that the magnitude may be valuable, and that is something that we have to think about all causes of death. But we can see here very encouraging data when it comes to that. So let's put it all together and see what are the benefits. So it's not only reducing the major adverse complications, and those are the lines with the little triangles, that's all on the left-hand side. Everything that's on the left-hand side is good, and you can see all-cause death is good. You can see non-fatal heart attacks, is reduced, etc. But also you can see the suggestions creeping in about heart failure. And now what we are hearing is that many patients, who have these benefits say, doctor, it's really valuable. I know I have reduced my risk of developing diabetes. I know I've reduced my risk of having a heart attack. But the thing that I value the most is now that I can walk further. Now I can climb up 2 or 3 flights of stairs before I'm short of breath. Now I can sit on the floor and stand up or play with my children or my grandchildren. So that is the functional gains, and especially people with heart failure have a significant reduction in functional capacity, but we can see that these treatments can really help that. So that is what is the patient-reported outcomes, the so-called the non-scalable victories. Those things about putting your socks and your shoes on, fitting into a seat on a roller coaster, getting on an airplane without needing a seatbelt extension, those are the value that these treatments can also bring. So we now need to think about, what is it that we want to do? And we want to have a comprehensive approach where we can not only reduce the number of fat cells that people carry, we want to reduce the risk of developing diabetes, their blood pressure, the inflammation, the CRP, but also the lipids. We want to improve the lipids. So therefore, you can see this is an holistic approach where we can really disrupt the disease of diabetes, but also disrupt the disease of cardiovascular disease. Now, what are the safety aspects? What happens if we have a nutritional approach, a pharmacological approach, a surgical approach? What are the safety aspects? I must say that it's very reassuring now that when we work with patients who have high cardiovascular risk, you can see on the right-hand side, the number of adverse events reported by the people who had the best diet and exercise approach was higher than the people who had the best exercise and diet plus medication. So actually the medications had fewer side effects than if we did not have the medication. And that's because of the multiple benefits that we have. So we can see that intensifying treatment does not mean more side effects. In fact, it means that we can reduce many of these adverse events that's driven by the disease, for example, cardiovascular disease in this instance. Now, of course, the medications in this case does cause, for example, more nausea, sometimes more diarrhea, constipation. So we have to be clever at managing that in a much better way. But overall, you can see when it comes to cardiovascular disease, other problems, for example, cancers, etc., there was no sign that the medications are doing any harm. And we have to be smarter when it comes to these gastrointestinal disorders, because nobody wants to feel nauseous. Nobody wants to, have vomiting, etc. So we as doctors have to be more conservative when we increase the doses of this. So we have to go at the right pace to really support the patients so that they have fewer of these side effects. You do not have to have side effects. So if you have any side effects, do speak to your doctor as quick as you can so that we can slow the dose titration down and help and reduce this as much as possible. So I'm going to summarize and suggest to you that what we have seen, if we intensify the treatment for people who have the disease of obesity and the disease of cardiovascular disease is that if we get double-digit weight loss, we can reduce major adverse cardiovascular events. This is also consistent with beneficial effects across the entire cardiovascular endpoint spectrum, and therefore we can have a real confidence that we can build on top of the already good treatments such as statins and ACE inhibitors and metformin that reduces cardiovascular events. So please allow me to thank the team at home that's doing all the hard work, our scientific team, as well as our clinical team, and I'm handing back to Johanna. Thank you very much.
Thank you so much, Professor LaRue, for that excellent presentation. I've also seen a question about if this will be recorded. It is, and it'll be released afterwards. It's so valuable to sort of break down some of these confusions around obesity and cardiovascular disease. And I think it's so important to highlight the need for consistent care and strong care plans between patients and their clinicians. So I really appreciate you sharing your expertise with us, and thank you again. I'm now excited to turn to our patient panel, and I want to thank them again for being here with us to share their perspectives and experiences. Susie, I'd love to talk with you first, if you might be able to come join me on screen.
Hi, Joanna.
So yeah, thank you, Susie, so much for being here. I'm really excited to get to talk to you. First, I'd love if you could introduce yourself and tell us why you wanted to speak with us today.
Sure. I'm Susie Burney, and I'm living in Dublin in Ireland. And I live with obesity. I suppose that's the very first thing I always say. But not only that, I've also over the years been diagnosed with some other associated complications that come with obesity. And I think I'm delighted to be here today. I suppose just connecting these different associated diseases. You know, there's not enough awareness about it. And I think when people actually hear the lived experience, they can sort of understand it a bit more.
Absolutely. I definitely agree with you on that. And I do think it's so important to uplift and highlight the patient voices, because at the end of the day, you all are the ones who have to experience the healthcare that's offered. So that's really helpful, Susie. Something that I think I've taken away from the presentation today is the need to treat obesity as a disease and offer tailored, comprehensive, and consistent care. Yet we know that there are barriers to that care. And one of those barriers would be stigma. So I'd really like to hear more about your thoughts on stigma and how stigma within the community and the medical community can impede access to healthcare.
Yeah, stigma, I suppose, when we hear the word stigma, we very quickly think we know exactly what it is. But when it comes to stigma and obesity specifically, it's quite complex and detailed and crossover. So we would have stigma in society. We all know that. We have stigma in the workplace. We have members who've said that from way back in the 60s. They were told, you know, they wouldn't get a promotion in their job, you know, because of their weight. You're just not suitable. Unfortunately, we have a lot of stigma with children. We can see it in the Mr. Men books. We see it, you know, in TV programs like Peppa Pig. Stigma is really pervasive in our society. But the top two really that affect most people living with obesity would be in healthcare and also within the family. Now, in healthcare was always the most predominant. And the reason we speak about that a lot is because it actually prevents people going for care. You know, they won't go to their healthcare provider. And we know from the Action IO studies that it can take a person maybe up to 6 years to discuss their obesity with their healthcare provider. And if I think back to my own situation back growing up, you know, I knew I had some problems growing up. I had a food disorder. I was very active and I started putting on weight from 13 and always blamed myself. I was fit and active and it didn't affect my health until in one single year, I was diagnosed with type 2 diabetes, polycystic ovarian syndrome. I had sciatic pain. And yet I was never once throughout all of this diagnosed with obesity. I was never told I had obesity. I was told to lose weight, surely. But I was sent to one hospital for my diabetes, a different hospital for the polycystic ovarian syndrome, and a weight management service for my obesity. But the worst stigma really was for myself, my you know, internalized stigma. And I think it's because if I bring in the connection here with cardiovascular disease, I've never had direct issues with that. But all of my adult life, all I heard from my mother was, I can't sleep at night, Susie, because I think you're going to die of a heart attack. And I felt so bad about that I then in turn could not move forward with what was right for me and the help that I needed. So that self-internalized stigma is a huge barrier. But the stigma in healthcare, I think, is, I suppose to put it into perspective of how it stops people looking for care, I'll give you just 2 quick examples. And one of them is Maura, one of our members, went for a breast check, and the nurse that was there was quite, I suppose you could say, aggressive in her manner. And she was saying, you know, stand closer to the machine now. It's, you know, you need to move closer. And Maura explained, listen, I can tear quite easily. And the nurse said, oh, you know, if you could lose a bit of weight, not knowing that Maura had already lost 10 stone. You know, not knowing her history at that point. And Maura did tear, and she left the unit quite upset. And she has said since she's never going back. That is just too much to go through. And Catherine, one of our members, she went for a gynecological appointment, and she overheard the consultant say, this is rather embarrassing, it's her weight. And yet when he came out to her in the waiting room with other people around, she said to him, have you seen my scan? And he said, oh, I didn't know you had a scan. You know, and she came to our ICPO meeting that night and said, I'm never going back. She was terribly upset. So for both of those stories, we wrote letters addressing stigma, and we wrote to both consultants or to the nurse and the unit to say that this stigma was stopping these patients going back for their care. And both apologized and came back with letters to say we weren't aware of what we were doing. And for the breast check, they said they'd circulated around the country. But the stigma, unfortunately, is a huge barrier for people living with obesity for getting their care. And from listening to Professor LaRue there, we know that if you treat obesity, you can prevent so much in all of the other, you know, the other associated illnesses.
Absolutely, Susie. Thank you for shedding light not just on your own experiences, but those of your community, because I think that does show a representative experiences that unfortunately so many people do have to deal with. And I think you've made some really excellent points as well as to how it only takes one bad experience to set someone outside of the healthcare system, possibly forever. Because I think perhaps in the clinical world, they might see things all day, every day, and if they become, it might not seem what it is, which is a hugely emotional and very personal experience for patients who deserve to be treated with compassion and with care. So I really do appreciate your perspective on that. And if I could follow up on one question, how have you seen things changing? Are things changing? Or what else would you say needs to change?
I think they are changing, probably not fast enough for what we would all like. You know, I think that's clear, but it definitely is changing. And we can see through all our campaigns at World Obesity Day each year, and you know we're moving forward. But the great work you're doing yourself at Global Heart Hub, you're leading, I have to say, in connecting all of these different disease areas, because people just don't understand it. Now, we did a webinar a podcast for World Obesity Day this year with 5 men. And when we heard the statistics there from Professor LaRue, it is that there is only 30% of men in the weight services, but yet the prevalence for weight, obesity issues for men over 50 is higher. And it's harder for them to talk about it. But when in this podcast they discussed it, a lot of the men are much more practical. And when they're told there's such high links with cardiovascular disease and type 2 diabetes, that can prompt them to act. Whereas for women, it's more the focus on, I think, the quality of life and the being able to play with their kids and stuff like that. And I think the more we raise that awareness of the link between all of these diseases, the more important it is that people will go and get help. Like we had Professor Donald Brennan from endometrial cancer join one of our support meetings. And when he told us of the high prevalence of endometrial cancer with women over 50, that it could be up to 70 to 80%. The shock within our members was huge. And I think we just don't have enough awareness of the links of all of these diseases. And I think we just continue what we're doing to raise that awareness.
Absolutely. And I think there's a lot of questions that are still unanswered, not only within the patient community, but within the clinical community as well. And we deserve answers to those questions. And that kind of brings me to my next question, which is, how do you suggest people living with obesity find the support they need if they want to learn more about their own disease and how to manage potential risks of CVD, knowing that there's so much stigma, possibly internally and externally, and it can be difficult to enter those kinds of spaces?
It is difficult. And I firmly believe that for anybody to try and get the most effective support they need it both from healthcare and from peer support. I really do believe that strongly, that not just one on their own is enough. We do hear a lot back from our community of people like who say that their GPs don't understand. We now have the model of care for obesity. We now have the new clinical practice guidelines. We are now doing stigma education talks for student healthcare, that we're raising that awareness. And I think that knowing there's support there and knowing there's science-based evidence for this now, you know, it's very hard to argue the science. And then when you hear the lived experience that backs that up, You know, I think that's important. So we need more people to share their stories. I'm delighted that Claire is going to be following now, sharing her story today, because it's not easy. And a lot of people think that to share your story, you're looking for maybe a sense of pity, but it's not, because how can somebody effectively treat us if we don't share everything that we're going through, the barriers? I mean, a lot of our patients don't talk about pain. They don't talk about, you know, the emotional distress that they go through. And until we keep doing that, they're not going to get effective support. Now, there's one area that I won't go into, is just the access our government need to fund. Obviously, if patients are going to get proper support, they need to fund this. And we're seeing changes there. We are seeing changes, and we'll just keep pushing at it for more change.
Absolutely. You've actually also highlighted an important point, which is that often the care that somebody needs or the information they're looking for might lie with a specialist or someone who knows a lot about this. But their first point of care is with the general practitioner or a community health worker, and they might not have the same understanding of obesity as a chronic illness. So along those lines, you know, what suggestions would you offer to medical professionals, not just specialists, but also GPs, on how to communicate the risks of CVD or the management of obesity to their patients?
That's a very difficult question, because we know that GPs are actually quite nervous about bringing up the topic of obesity, for one. And as I said, not many people would say they're diagnosed with obesity. So sometimes there's that sense of scaring the patient by putting another one on top, like the cardiovascular disease and that. But I think once there's a compassionate dialogue between the healthcare provider and the patient, and what I mean by that is that you ask permission first to have that conversation about the person's health. We've seen many times that patients go in to see their GP and they could have a sore elbow, and they're told, well, if only you lost a bit of weight, you know, and that's not helpful at that point in time. That's not the right discussion to have at that point in time. I don't know, with GPs, and at that point, it's very difficult. Like we see in some groups, patients say, just change your GP if he's not listening to you. It's not so easy, you know. So again, I suppose pointing to clinical practice guidelines, and that there is scientific based evidence there. But yeah, I think just what we're doing, Joanna, is raising that awareness more and more about the links between these associated illnesses, because there's just not enough awareness.
Absolutely. And I think as things move forward, if we can build these links and build this awareness, it also encourages medical professionals to build a relationship with their patients and come up with a care plan together that both people feel will work and both people can stick to, instead of being handed a plan that you're not involved in and you don't feel too encouraged to really follow through with.
And that's the word there, a care plan. And what we see an awful lot is that we hear about prevention and we hear about a treatment, and many patients, particularly with obesity, think that once they've got their treatment, that's it, they're done. But it's not, because it's a chronic relapsing disease. So you need actually treatment for life. As we heard Professor LaRue say, once it's stopped, the obesity can come back. You know, the symptoms of the obesity can come back and affect you. So we need to talk about management, the care plan. And I think many GPs don't understand that long term. And we're still back sometimes in the old ages of eat less, move more. When we know for somebody with obesity, it's so much more complicated than that. So yeah, we've got to move on with the narrative, I think.
Absolutely, moving the needle. And I really appreciate you being here, but also all of the work that ICPO and ECPO does in this realm. I know you all have made such progress and you're continuing to do that. Thank you so much for your time, Susie. I really appreciate it. And again, all the work that you all do.
Thank you.
I'll now call forward Claire. I'm really excited to talk to Claire today as well. I know that you had to join with your phone, which is just all right. So if you might go ahead and introduce yourself, tell me why you wanted to join the webinar today.
Okay, I'm Claire and I live in County Galway, and I've been living with obesity for most of my life, all of it. And in 2021, I had a heart attack. The reason I want to is because I think the more patients speak out about their experiences, people will start to listen, and other people will also be encouraged to speak out as well.
Absolutely. I mean, we heard from Susie talking about stigma and some self-internalized shame and how that can keep people getting the care they need, leading on their friends and family. And the more people do speak out, the more we're able to break those down. So welcome, Claire, and thank you so much. I'd like to hear a little bit more about your experience in managing these sort of connected conditions, in this case, obesity and cardiovascular disease. Would you say you experienced treatment of these two conditions separately, or have you been able to have more holistic or joined care?
Definitely separately. with regards to the heart attack, it was straight into the hospital, a procedure done. My first memory after the procedure was I was actually asked if I could lift myself off the operating table onto the trolley. And I think that was the first time it really hit home about my weight. And after that, it was all internal. Anxiety just came across right until when I left the hospital and everything. Any other treatment after that was 6 weeks later, I had a checkup. Then, because it was during COVID, I got lost in the system. And only from constantly going back to my own doctor that I eventually got an appointment in 2023 with regards to checking all my medication, because I had been on a tablet for 2 years, which would only have been 1 year.
Mhm.
But through all of that, it was the mental side of trying to deal with things and not having any support on the mental side, or even a group that have experienced cardiovascular disease to talk to. It certainly would have helped. But with regards to the obesity, then I only had my appointment in January this year in the endocrinology department. And I'm being put forward now for the plan sessions in with Cree. Outside of that, there hasn't been anything else other than me trying to do bits myself. And between the cardiology and the obesity, if you're living alone, you don't have family near you, you may have a few friends, but they wouldn't necessarily be people you would want to discuss these things with. You do feel very isolated.
Thank you for sharing that with us, Claire. And if you don't mind, I'd like to hear a little bit more about that isolation after an event like this, because it sounds like not only were you physically very isolated from other people, but having to come to terms with an event or a new diagnosis is also very isolating. And when you don't have something like comprehensive or holistic care, it's hard to know where to turn to educate yourself, to get the resources that you need, or to get the emotional support you need as well. Would you say that resonates with your experiences, and how would you like to see things change?
Oh, definitely, because I think after having a heart attack, I think you may go through a period of denial, and eventually you get to acceptance, and depending on the person's personality, that can be different over time. But it does lead into other things, ending up with anxiety, or in my case, I ended up having panic attacks, which I'd never had before, and being paranoid, not wanting to go out, afraid to go outside the door, afraid to overexert myself. What I'd like to see done is when a patient is in being released from the cardiac unit, that there is a support there, not just physical, as in the rehab, but for mental support as well. And if nurses, you have the cardiac nurse, if they were trained to a degree with obesity, or in how to talk to somebody who is living with obesity, it would make it easier to slide into the other services when you eventually get them. You would feel more comfortable talking to other professionals and being able to open up to them as well. So leaflets for to start off, and the option then leaving it up to the other person whether they want the rest of the help or not.
Yeah, so it sounds like the ability to meet with somebody who's educated on all of your conditions or the connectedness of those conditions you can share with you, so you're not left sort of on your own to figure it out. And then they could point you to other resources like handouts or PDFs or patient support groups where you can find some emotional or peer support that could have gone a long way after your event. Can I ask you, in terms of before you experienced your cardiovascular event, what do you wish your clinicians would have given you, or how do you think you would have wanted them to communicate your risk or an understanding of cardiovascular disease beforehand, and how might you suggest they change the way they discuss these kinds of things with their patients in the future?
For before I had my heart attack, I think it needs to start with your GP, but it also brings in your family history. And you can get a certain amount of education from your GP, because you're not going to see a cardiovascular surgeon until there is an issue, basically. So whether the option would be to do outreach groups when they're going around to talk to different people about different things, that it could be brought up. But on a one-to-one basis, I do think it needs to start with your GP, if you have a GP that's willing to take that step. For both
Absolutely.
talking with cardiac and obesity.
Absolutely. And it does kind of bring us back to the point we were talking about with Susie, which is the idea that a GP or a primary care provider is your first sort of line of defense when it comes to your care. And if they have the knowledge and the ability to discuss with their patients and build a strong relationship with them, they can set them on the track for positive care, comprehensive care, and we all as patient organizations and advocates should be pushing for GPs to have the education and the abilities to do that. And I really appreciate you sharing that with us as well. That kind of brings us to the end of our time together. Thank you again, Claire. I really appreciate you sharing your perspective and experiences with us. It does highlight how real and personal these issues are, and I really appreciate you taking the time to join us today. So thank you again.
You're welcome.
And now for our last few minutes, I'm really excited to bring Vicki Mooney up onto the screen to share about what is happening or what needs to happen in policy to make a real change for patients. Vicki, please go ahead.
Thank you so much, Joanna, and thank you to Claire for something that I got quite emotional listening, because I think, what Claire has been through, and what we see as more professional advocates, it really hooks the emotions, and that is exactly what we try to do when it comes to policy. And the policy, I call them policy gatekeepers, not policy makers, because effectively they are the gatekeepers to what we actually want to achieve. And so I'm very grateful to Claire, and I'm glad that you're on screen. I can see your knitting behind you, which is therapeutic and wonderful. And to Susie, who I've worked with Susie for such a long time now, and we're a bit of a tag team when it comes to working together. Now, for me, there's only a couple of slides that I wanted to share, and it was when Susie and Carl were speaking that I kind of wrap my head around a couple of things that I thought would be good to share on screen. But before that, we're talking about what changes to policy and practice, what needs to change in clinical practice and policy. Really and truly, it's the science that Carl LaRue presented to us. Obesity as a chronic relapsing disease is a gateway to various other complications and NCDs, over 229 of them that we know, over 13 cancers that we know of. And it's, for me, the biggest challenge since I've been going in and out of the Parliament the last probably 8 or 9 years with EASO, the European Association for the Study of Obesity, has been that the science and the policymakers are not aligned. They do not understand the science that Carl LaRue presented. And unfortunately, nor does the average person in society either. Now, one thing that really goads me when I actually engage with policymakers and the community is that there is always the lifestyle discussion. And in every single policy strategy that we have seen across Europe, I read every page of Ireland's, beating obesity, tackling obesity by 2025. And effectively, it is health promotion for everybody. That is all it is. If you have hypertension, you go to your doctor, he will tell you to eat well and to exercise. If you have cancer, you're told to take care of your body, look after yourself, eat well, get all the right nutrients. And this is in every prevention plan, and this is just pure health promotion. So being a patient can be very powerful, where I have my own lived experience. I've been a patient all of my life. I've had various different treatments. From here up, I mightn't look as if I've been an obesity patient of almost 200 kilos at one point in my life. But I think this is where patients can be very, very bold. And one thing that I think is really important for us to do is make sure we align that science with the policymakers, and that will impact clinical practice. Now, how do we actually do that? That is the biggest challenge. But as patient organizations, ICPO, ECPO is a European organization, which I'm the executive director for, and Susie actually sits as secretariat for us. We work across 30 plus countries. And what we do is we take publications, we take the research, we take like presentations that Carol showed, and we change terminology into the language of the average 12-year-old, because health illiteracy is a real problem. And it's something that I think needs to change, and is changing now. Finally, within the EU, there's a lot of push for better health literacy, but we change it into scribes and infographics. And I'll actually just share a screen. I hope I share the right screen. You're not going to see like my child from earlier today. Let me just see. Yes, hopefully that is the right screen. Yes.
Looking good.
Okay, then. Okay, so I'll go into presenter view. Okay, and I'm going to go back actually too, because when Carol talks about obesity as a chronic disease, it's key that people understand it. And we did this training in Budapest last year, and we had over 30 of our members from across Europe attend to understand what obesity was. And as Jens Christian Holm was explaining, like Carl did, a lot of people, it still just they didn't grasp it, because there's a lot of terminology. Like, we're not doctors, we're not scientists, we're not clinicians. So effectively what we do is we take the science, we turned them into infographics, and we shared them with our community. And this one was on obesity as a chronic disease. And then this one was on weight stigma and weight bias. And we put these out in social media. We have so many of them at this stage, so that we can actually start to change the perceptions of society in what they're actually talking about in the research area, what the clinicians are talking about, and what the policymakers need to hear as well. And if we have society pushing for disease recognition, instead of just, it is all your own fault. Yes, everyone has a responsibility to their health. I have a responsibility to my diet and my fitness, but that is not going to stop the fact that I have biological or genetic obesity, and I cannot fight my own biology. I need intervention, and I need a clinical pathway for the life course. So really and truly for me, like it comes down to ensuring that people are educated, and that they understand how to speak to somebody about obesity as a chronic disease, and also then to actually talk to their policymakers. And until we actually get that, that's not going to happen. But this is the other slide I wanted to show you, and this is actually from EASO, who are the European Association for the Study of Obesity that I mentioned. There's their website there. And this is what we will turn into a plain language summary. And this is key, because this is framing the correct language for policymakers, for all of those that we engage with in the clinical setting and everything else, to ensure that obesity is recognized, like cardiovascular disease, as a chronic disease. And that is really, really key. So I'm going to stop sharing my video. I'll actually put the link to this piece in because IASO have only actually released this as of yesterday. So I'll stop sharing my video now because there was a, oh, okay, hold on. Am I still screen sharing or am I on video? There I am. Okay. So the other thing that I actually wanted to kind of just share, because I know we're going to run out of time also, is that, you know, when we actually change the terminology, we need to look at what's working and what's not working. And within the European Parliament, we had the MEP interest group who were working heavily to have disease recognition for obesity, which would open the doorways for us actually treating obesity and not just trying to prevent it, but treating obesity to prevent other NCDs. And as we all know, the Commission and the Parliament, everything has changed now. We've 720 MEPs in the Commission, and this is our opportunity to actually work together as various organizations in different disease areas that all overlap and actually, you know, be stronger in our voices. We have engaged with WHO on the acceleration plan. Now, if you are aware of WHO, they had predominantly only like looked at obesity as prevention, you know, and the usual public, you know, promotion, health kind of message. But we worked with them and then they put management in. And that management is on training at a primary care level that obesity is a chronic relapsing disease. So effectively, we've a bit of a battle on our hands. We need to unite. We need to get stronger together with our voices. We all need to work together because my father died at 54 from, he had had 4 heart attacks before he passed away. He had a quadruple bypass and he passed away 4 years later with a massive heart attack. My grandmother passed away with lipedema, type 2 diabetes, sleep apnea, hypertension, cervical cancer, MAFLD, you name it. She had everything linked to obesity, but she hadn't got any treatment for her obesity. So when we all come together, that's when we can see exciting developments and change. And that's where we need to bring our experiences, but also a really, really strong call to action on the back of that to all of these policy gatekeepers and to the people that are out there to listen to us. So, you know, we need to stand strong together. We need to work together. And I'm just very, very grateful that you've given us the opportunity to work with Global Heart Hub on this empowering webinar. And I hope that we have empowered some people to act, to be active, to get more involved. So thank you.
Thank you so much, Vicky, for your discussion here today. I'm really, grateful for you taking the time and sharing this with us. Not only your presentation, but so many years of deep expertise and knowledge in this field, and for highlighting what needs to happen moving forward, because it is essential for all of us and for all patients to get the care that they need. So I know that we are running short on time. So first, I want to thank all of our panelists for joining us today and sharing their experiences and their expertise with us. I really appreciate you all being so generous with your time. And I know it was a really valuable learning opportunity for me. Of course, I'm also grateful as well to have been able to partner with ICPO and ECPO on this webinar, who are doing amazing work across Ireland and Europe. And I want to thank Susie and Vicky in particular for their partnership, and Claire for sharing her personal experience. Thank you as well for everyone in our audience. I appreciate you spending this time with us on this webinar, and I hope to see you at future webinars. You should see a survey when you exit the webinar, which I hope you'll take the time to fill out so that we can continue to improve. And of course, we'll be sending out a recording and the slides from today's session to all attendees. For anyone who's interested in learning more about Global Heart Hub's work, I encourage you to reach out to me. Thank you again, and I hope to see you next time. Bye, everyone.